Approximately 1.4 million Americans have inflammatory bowel disease, or IBD, with about 30,000 new cases diagnosed each year. Two major forms of IBD, Crohn's disease and ulcerative colitis, affect patients in roughly equal numbers.
IBD is caused by an overactive immune response in the large or small bowel, and the immune system is over-responding to the normal bacteria that everyone has in the intestine. This causes inflammation, breakdown of the surface of the intestine, and the symptoms then become diarrhea, abdominal pain, sometimes bleeding and weight loss. It can be very uncomfortable for patients.
Treatment for IBD requires an accurate diagnosis, which is based on medical history, a physical examination, and results of endoscopic, radiologic, and pathology studies, in addition to routine laboratory tests.
Most often we can differentiate between the two diseases by looking at a list of clinical characteristics as well as other factors. So we'll look at where is the disease. In Crohn's, it can be anywhere in the GI tract. In ulcerative colitis, it's just in the colon. We look sometimes at some blood tests, sometimes under the microscope what it looks like. Still, in perhaps 5% of the time, when we look at everything together, we still can't tell the difference between the two diseases.
The primary treatment for IBD is medical therapy to induce and maintain remission and improve the patient's quality of life.
The medicines prescribed for IBD are generally medications that will suppress the immune response or the inflammation in the intestine. And these are a whole variety of different agents, which include purely anti-inflammatory agents to steroid medications to gently immune-suppressing medications, and most currently there are biologic response modifiers such as anti-TNF antibodies.
However, when medical therapy is not enough, a significant percentage of patients will ultimately require surgery.
For ulcerative colitis, the disease is confined to the colon or large intestine. So basically the operation that we do is to remove the entire colon and rectum and usually nowadays put things back together with what's called an ilioanal J-pouch operation. For Crohn's disease, it's a little bit different. Crohn's disease can affect the small intestine as well as the large intestine. And the operations are either to remove a small section and put things back together, or even better, to fix the problem with what's called a strictureplasty, which is a way of opening up the bowel to relieve a blockage.
I was diagnosed with Crohn's colitis. I was in a hospital with severe pain for a couple of weeks and was transferred to Mass General. I had a perforated colon, so I had emergency surgery, and that resulted in an ileostomy bag. Within a few months, I was able to have my bowel reconnected, and I am currently taking azathioprine, and right now I have no symptoms and I feel really good.
When I met Tracy, she had an ileostomy where the stool comes out into a bag. And what we did was remove the ileostomy, and we took the end of the small intestine, the ileum, and made a pouch, or what's called a J-pouch, and we put things back together with the rectum, which was healthy. So now she's able to eat normally, has normal digestion, and the functional outcome has been quite good.
New research by physicians at the Crohn's and Colitis Center at Massachusetts General Hospital suggests stimulation of the innate immune system has significant benefits for some patients.
It's very exciting in that it's the exact opposite of what most standard approaches in Crohn's do. We're looking at stimulating the immune system as a way of trying to treat what may be the fundamental underlying problem in Crohn's disease. When we first started looking at this, we were afraid that we would be throwing fuel onto a raging fire, but really the opposite occurred, that many people who hadn't responded to other therapies responded very well, and we're hoping perhaps it may also be a safer approach.